We were TACE heavy up until about 2018, and obviously transplant allocation changed. So our access to livers, we went from being number one in liver transplant for a decade, making it on an episode of The Simpsons, Oshner. But obviously patients were not getting livers like they used to, and so we needed a more durable response. So we switched, and we see the same kind of stuff that was produced in Legacy by switching over. And that was, interestingly, I heard Riyadh just say this, that Y90 has replaced TACE as the primary bridging strategy for transplant patients.
In the United States.
In the U.S., yeah. Okay, so we're talking about simple rad-seg. We talked about threshold dosing and then dose optimization, and we'll get back on voxel-based dosimetry. But before that, y'all alluded to this, dosing to normal. What are your target strategies when you dose to normal? Like maybe you're doing a palliative approach, right? We're not going curative intent anymore. What are your thought processes in dose to normal?
Well, and you said we're not going curative, but that's really going to depend on, again, what my intent is, because there's also if we're doing a modified radiation lobectomy to, bridge somebody who doesn't have enough FLR, the way I'm probably similar, but in that case, I'm usually doing an ablative dose to the tumor, right? And then I'm doing at least trying to dose to 100 to the normal, right? Because I'm trying to get that hypertrophy on the other side. We've seen on data that as long as you're getting above 88, that's it. When I'm treating multifocal tumor, let's say unilobar multifocal tumor, I'm still, honestly, the way radioembolization has evolved, I'm still mostly thinking in a rad-seg way, right? So if I can get selective to treat 3 tumors, then I will do that. But if we're actually going, if I can't even remember the last time I just did a single lobar dose to treat multiple tumors instead of getting selective. But in that case, that's when you're actually thinking about that dose to normal. And usually I like to keep it around that range.
So this is a great point you emphasized right here. So if you had somebody that had multifocal tumors, we don't necessarily have to treat with one dose to the lobe, right? You can select them out and do multiple rad-seg.
So I am of the mantra that the way to really save the background liver is to get selective, right? So if there is, and I do this for HCC, and I know this is an HCC session, but metastatic disease. So if I can get selective to multiple tumors, I would rather do that and give several doses than just giving a lobar dose.
I'm exactly the same way. I like being able to highlight that, and you brought up a good point that I totally passed over.
What if you can get selective to some tumors, but then some you can't? They're more central. Then does that change? Do you do a lobar dose then, or do you do the boost dosing where you?
Yeah, I might. Again, I'll always try to get, if there's a way to get selective, I'll get selective to those. In that case, I might maybe stage. But, honestly, bilobar diffuse HCC at our institution will probably go to systemic first, right? So the days where I'm just giving a lobar dose just because, I'm always modifying my lobectomy usually. Either, double segmental approach or doing an ablative dose to the segment followed by just a lower dose to the rest of the liver.
I agree completely with everything you said, and I have a very similar philosophy with how I treat. But for the people out there coming out of fellowship, it's very smart people, one sitting across from me, and then also similarly for resume careers as well, develop dosing guidelines. There's journal articles you can go to that have extensive, and they have every single scenario, right? And so one of the scenarios is what you mentioned, palliative dosing, not ablative dosing, what targets do you hit? I believe in the most recent guidelines, and if you can correct me, I think it was background liver dose of 80 gray with glass, and then 40 gray is what the resin target is. So below 40, again, the 2-to-1 ratio popping up again.
Getting at least 205 to tumor. So you want to think about
Correct.
That tumor dose,
yep,
yeah.
Right, but yeah, exactly. So I recommend for everybody out there who's wanting to get more advanced with their dosimetry, go to those guideline papers, right? Because people put a lot of thought and effort into creating those, and that's always a great place to start.
And they're actually really straightforward. Like there are scenarios, they have unilobar, it's actually really great.
It really does, and I think that's
simplified.
We hit that, and that's we always. Yeah, I think if you follow guidelines, you have footholds to stand on whenever you're justifying your approach. I think it's hard to challenge somebody that's following guidelines with the way that they treat. So dose to normal, we'll say for glass right around 80. For resin, we'll say right around 40. And you talked about this, that when you're trying to do rad-low to hypertrophy the contralateral lobe, rad-lobectomy to hypertrophy the contralateral lobe, you're targeting what kind of dose to normal?
100. At least over 88 is what the data has shown, but I personally target 100. And I think that's what the guidelines in those papers say as well.